At Chapin Hall. We're so excited that you're able to join us today for what I'm sure is going to be a really engaging webinar. I want to, welcome Cohort 6 and Cohort 7, and it looks like we have several graduated fellows with us as well, so welcome to you all as well. Just a few pieces of business before I hand it off to Leanne to introduce our speakers for today. I'm going to keep you all muted throughout the duration of the presentation. If you have any questions that come up during the presentation that you want to make sure you ask our speakers, feel free to use the questions chat box, or not chat box, but the questions typing box in your webinar panel, control panel. And if we need to clarify your question in any way, I will unmute you in order to do that. But just know that you'll be muted for the whole presentation. I think those are my pieces of business. So without further ado, I'm going to turn it over to Leanne to introduce our speakers for today.
Thank you, Sarah. Welcome, everybody. I hope you're all having a good summer so far. What I'm going to do quickly is introduce Amy and Renee, who are going to present the material for the webinar. And then, as Sarah said, we'll have some time for questions at the end. Many of you have met Dr. Amy Dworsky. She received her PhD in social welfare from the University of Wisconsin in Madison, where we've had several fellows from, and at least one current fellow is there right now. Amy's a research fellow here at Chapin Hall. She's widely recognized as an expert on pregnant and parenting foster youth and on homelessness among youth who transitioned out of the foster care system. Amy's spoken at a couple of our meetings in the past, so hopefully you all will get to meet her in person at our annual meeting this fall. And then we are especially excited to have Dr. Renee Wilson-Simmons with us. Renee earned a PhD in maternal and child health from the University of North Carolina at Chapel Hill, where we also have one current fellow, I think, and a couple of graduated fellows who are working there. Renee is the director of the National Center for Children in Poverty, which is one of the leading public policy centers dedicated to promoting the economic security, health, and well-being of America's low-income families and children. Her career has focused on the health of young people across numerous domains, including reproductive health, violence prevention, substance use, and healthy development. We're honored to have Amy and Renee with us today. We thank you both for your willingness to engage with our fellowship, and I will now turn it over to Amy.
Okay, thanks, Leanne. Sarah, can you advance the first slide? So I'm going to start by talking about the issue brief. I believe everyone received a copy of it from either Sarah or Leanne. I'm going to talk a little bit about the substance of the issue brief, and then after I do that, I'm going to turn it over to Renee, who's going to talk about the importance of collaboration between policy advocates and policymakers and researchers. So I'm going to just start with a little context about young people aging out of foster care for those of you who are not familiar with this subject. So every year, about 25,000 young people age out of foster care. And by that, I mean that they reach the age in their state where they're no longer eligible to be in foster care. In some states, that's 18, and in other states, it's 21. Many of these young people, once they age out, find themselves on their own with little or no family support and little or no support from the government. Because of that, there's been a lot of concern about what happens to these young people. There have been a number of studies done over the past 2 or 3 decades, and the results of these studies have been pretty consistent over time. In general, they find that young people who've aged out of foster care are at high risk for a number of adverse outcomes. And by that, I mean things like low educational attainment, low rates of employment, various economic hardships and homelessness, high rates of incarceration, and high rates of early pregnancy and parenthood. One of the obstacles that these young people face that hasn't gotten quite as much attention has been a lack of health insurance coverage. And so as a result of that, many of these young people haven't had access to health care. Next slide. So there's a number of reasons why lack of access or lack of health insurance coverage and lack of access to health care is particularly important for this population. We know from other research that has been done on young people in foster care that they have much higher than average rates of physical health problems, as well as social and behavioral problems. And these problems don't just go away when they become young adults. They often persist well into early adulthood. Young people who are aging out of foster care have much higher rates of mental health problems, substance use problems, other health conditions than their peers in the general population. We also know that this population, as I already mentioned, is at very high risk of early pregnancy and parenthood. And these rates, again, they remain high even after young people age out of foster care. What we also know from other research that's been done, not specifically with young people in foster care, but with low-income young adults more generally, is that there's a positive relationship between providing health insurance coverage and contraceptive use. In particular, a number of states in years past have gotten waivers, for example, to expand their Medicaid coverage. And when they've done this, it drastically increases the number of young women who use contraception, thereby reducing the risk of unintended pregnancy. So, you know, one of the benefits of doing something like extending Medicaid coverage to young people who've aged out of foster care is that it could result in fewer unplanned pregnancies among this group. So I'm going to talk about some of the provisions in the Affordable Health Care Act that were aimed specifically at young people aging out of foster care. The most important is that under the ACA, young people who were in foster care and enrolled in the Medicaid program in their state on their 18th birthday, or in states that let young people stay in foster care till 21 at that older age, they are eligible for Medicaid coverage until age 26, and that's regardless of their income. There's no income or asset test, so they're categorically eligible. So if they meet those two criteria, they were in foster care and enrolled in Medicaid on their 18th birthday or their 21st birthday, if it's one of the states that extends care, then they're eligible until age 26. And that was supposed to mirror the provision that lets young adults in the general population stay on their parents' health insurance coverage until they're 26 years old. So it's supposed to create some sort of equity for young people who age out of foster care. The other important thing to note about this provision is that it didn't just apply to young people who were aging out when the law took effect, but it also applied retroactively. So if you were a young person who, say, had aged out of foster care in 2010 or 2012, that provision still applied to you since you would not yet be 26 years old. So it affected all young people aging out after or beginning in 2014, as well as those who had aged out in previous years who hadn't had their 26th birthday yet. And the Pew Charitable Trust looked at the numbers of young people who'd been aging out over time and estimated that beginning in 2014 that provision would help cover about 180,000 young people. So it's not a trivial number. And one other thing to note is that this Medicaid expansion for former foster youth is mandatory. So it's not like, if you remember, for the Supreme Court had that decision where states could opt to expand Medicaid to certain low-income adults. This provision for foster youth is not an option. It's not something that states can decide yes or no. It's a mandatory provision. Next slide. So all of that is really good news, but there was also a problem with the way the law was worded. So when you look at the wording of the statute, what it says is that states have to provide Medicaid coverage to youth who are in the state's custody when they aged out. And states have, a number of states, actually a majority of the states, 37, have interpreted that provision to mean that they only have to cover youth who aged out in their state, because they say the word "the" means that it applies only to them, as opposed to if it said a state, which would kind of be more general. So they're reading the law to say that they only have to provide coverage to the young people who aged out in their particular state. So if a young person, say, ages out in Illinois and moves to, I don't know, Kentucky, for example, Kentucky could argue that we don't have to cover that young person because they aged out in Illinois. And states also pointed to a document that was issued by the Centers for Medicare and Medicaid Services. They've issued an FAQ, and one of the questions in that FAQ was, are individuals who are in foster care and enrolled in Medicaid when they turned 18 or aged out of foster care in a different state eligible? And as you can see, the answer from the CMF was that we do not believe the statute requires states to cover individuals who are in foster care and enrolled in Medicaid when they turned age 18 or aged out of foster care in a different state. Now, if you notice the second part of that, they go on to say, we believe the statute provides states the option to do so. So as I said, 37 states are denying coverage, but there are 13 states, and there's a list of them in that issue brief, that are opting to cover everybody. So yeah, there are 13 states that have taken that step. So in terms of the sort of reasoning that states have for taking this position, a lot of it is driven by cost, right? So providing Medicaid coverage to all former foster youth is a cost for states to bear. The federal government does provide reimbursement for some of that cost, but it's not 100% reimbursement. They reimburse states at their regular Medicaid matching rate. There's an enhanced rate for newly eligible adults, but that doesn't apply to former foster youth. It's only the basic Medicaid matching rate. And that ranges from, I think it's 50% at its lowest, and it goes up, I think, to maybe 80%. I can't remember the exact figure in very poor states like Mississippi and Louisiana and Alabama. They have very high Medicaid matching rates, but you know, in some states it's as low as 50%. So, you know, if you think about it, in the long run, states may actually be incurring more costs by denying Medicaid coverage, because we know what happens when people don't have health care coverage. They don't go to the doctor, they don't get preventive care, little things become bigger things, and the next thing you know, they're in the emergency room, and that's the most expensive type of medical care that there is. So, you know, states may, you know, be looking at the short-term costs, but, you know, over the long term, it might actually be money saving if they provided coverage to these young people. And then the other potential source of cost that some states have raised is the cost of verifying eligibility, right? So if a young person was not in your state when they aged out, you still would need to verify that they were a former foster youth and that they were covered by Medicaid when they aged out. And there's no national database, there's no national electronic data system out there that you can query to see if, John Smith was in foster care in the state of New York on his 18th birthday. I mean, there's no system. You have to call New York State, track down his caseworker, or, track down the agency, and, obviously that all involves time, and time is money. So that's another potential cost to states that they've raised. So what we know is that as of April 1st last year, there were only 13 states, as I said, that have opted to provide Medicaid coverage to all young people to age 26, regardless of what state they aged out in. There aren't any really good data out there on the number of young people who've actually been denied coverage. And this would be young people who aged out in one state and moved to one of those 37 states that are not providing coverage to everyone. There's just no good data on how many young people have been affected by that. The other thing is that some of those young people who move from one state to another may still be Medicaid eligible under another category, right? So they may be a low-income pregnant woman. They may be a low-income adult who qualifies as a newly eligible person if they move to a state that took the Medicaid option. So not everyone would be ineligible, but they would no longer be categorically eligible under the former foster youth provision. There have been efforts both in the Senate and the House to revise the language to address that issue, that problem with the wording, so that it would apply to all young people. But as you can imagine, in this atmosphere right now, given that the Republican-controlled Congress is dead set on repealing ACA, it's very unlikely that is going to become legislation anytime soon. And the last thing I want to talk a little bit about that we also address in the issue brief is barriers to Medicaid coverage. So the law says all of these young people, they're eligible for Medicaid coverage, but there's also some barriers for that to happen. The first is that in many states, young people are required to document their Medicaid eligibility. It's not something that automatically happens when they age out of foster care. And sometimes young people don't know that they're supposed to actually document their eligibility. They don't know that they need to take those steps and enroll. And so some young people are falling through the cracks. Another is that young people in some states are required to go through eligibility redetermination every year, or possibly even more frequently. Even though they're supposed to be categorically eligible until age 26, regardless of their income, in some states they're being required to go every year and recertify that they're eligible. And then finally, some young people are just not being educated before they leave care that they are eligible for this benefit. So they have no idea that they need to apply. They don't know. No one's telling them that you're eligible for Medicaid. It lasts until age 26, but you need to take these steps. If they don't have that information, they may not be able to benefit from this coverage. So there's some strategies that states could take or could implement to address these problems. One, as I mentioned, they could automatically enroll young people as they age out. They could work with their Medicaid agency to make sure that those young people are automatically enrolled. The application process could be streamlined. There could be a national registry, for example, of young people who age out of foster care that states could query, which would address that cost issue that some states have raised. It's important to ensure that young people are educated about this benefit so that they know before they age out. And then finally, I think one of the big challenges is these young people who aged out before the provision took effect, before 2014, using social media, tapping into other social networks, partnering with organizations that work with that population to try to inform them about their eligibility, because there are still young people out there who aged out before 2014 that are eligible and may not know it. And so for that, I'll turn it over to Renee.
Renee, are you able to hear us? I'm not sure that we're able to hear you right now.
Sure what to do. I could hear you clearly. You can't hear me at all?
Oh, now we can hear you, Renee. Yes, now we can hear you.
Oh, thank goodness. Okay. So, am I clear?
Yep. Now you are,
okay.
Yes.
I don't know what happened. Okay, so thanks very much, Amy. And I know that one of the things we were asked to talk about is the process of working together, sort of an advocacy/policy person and a researcher, sort of how we ended up working together in the first place and what the process looks like, as well as what strengths and weaknesses each of us brought to development of the brief. And we were also asked if we could offer suggestions for how fellows might create relationships or look for opportunities to do this type of activity. So I'll start us off, and Amy, please feel free to jump in at any time. Then once I've shared a few of my thoughts, we'll open it up for questions. And I'd like to start by sharing one of my favorite quotes, and it's this: "Power concedes nothing without a demand. It never has, and it never will." And those are the words of Frederick Douglass, a African-American social reformer, abolitionist, orator, author, and statesman. And while I believe that his words are true today as they were when he uttered them almost 100 years ago, effective advocacy needs facts, and facts need advocates. Because without facts, without data, you're just another person with an opinion. That's the favorite saying at NCCP. You're just another person with an opinion. So let me share a little bit about NCCP. So NCCP is housed in the Mailman School of Public Health here at Columbia University, and it's comprised of staff representing a range of disciplines. I mean, obviously public health, but also sociology, educational psychology, economics, early childhood education, political science, educational administration, statistics, and library and information studies. And those right now are all of the disciplines that the current staff possess. And our task is to conduct research and then translate the findings into actionable recommendations for those in positions to affect change. And the focus is really on actionable recommendations. And so while we may be considered advocates by some, we really are first and foremost researchers who are focused on the use of research, and for us, it's to improve the lives and futures of low-income children and their families. And so if you could go to the next slide. And because NCCP understands that it's not just about policymakers, that we have to change minds and mobilize public will in order to influence policy, the center reaches out to many stakeholders, trying to make them partners in our efforts. So of course, we're talking about policymakers, and that means helping them sort of understand and then adopt what the research is telling us are the most effective programs and policies that can reduce family economic hardship and the negative effects of poverty on children. We try to work with service providers in their efforts to turn the research into practice and identify and implement research-based programs. We support advocates as they try to develop and implement plans to influence public policy and resource allocation decisions, because policy without the funds and support for implementation isn't a word useless. We collaborate with other researchers in efforts to sort of deepen our understanding of public policy issues, and then to identify and advance what the research is telling us is best for promoting healthy development. And it also means aiding the media in their attempts to tell the stories of poor children and families in America, but not just to tell the stories, but to really shine a spotlight on the power of prevention. So because our primary focus is on policy change and we're conducting research to achieve it, we are both researchers and public policy advocates. However, we are a center that's housed within an academic institution. So we're fixed firmly in the research world with an understanding of the difficulty of achieving policy change without advocacy. And that makes us a sort of a hybrid, but truthfully, because we're not skilled advocates, and we would be the first, well, maybe not the first to admit it, but we have to say we're not skilled advocates. So we're constantly looking for ways to develop strong partnerships with advocates that will increase the chances for success. And because we're a small group, we're a staff of 21 with the students, both undergrad and grad, and interns from time to time, but a core staff of about 21. We also know that there are many areas of expertise that we just don't have. So it makes it essential that we develop partnerships with researchers whose knowledge and expertise will enable us to address issues that we just can't take up without their engagement. And I think this policy brief is a prime example of that need and the way in which we met it. So here's the short version of the story. So before I joined NCCP, I was if you could stay on that slide, please. So before I came to NCCP, I was a senior associate for adolescent health and development at the Annie Casey Foundation, and I transitioned the portfolio to the reproductive health of youth in and aging out of foster care. And I met Amy during that time, and when I moved on to NCCP, I still wanted to lift up the needs of that population. And because I didn't have staff to work with me on this issue, I worked over 2 summers each summer with a student from CDC's Public Health Scholars Program. However, once the policy brief was completed, I really knew it wasn't as thorough as it needed to be, and it wasn't as strong as it needed to be. And what it was missing was an expert's review. And so I immediately thought of Amy. I reached out to her. She kindly and graciously and generously agreed to review it. And she did such a thorough job suggesting sort of significant revisions, and many of which she ended up actually writing, that it was kind of a no-brainer on my part to make her the second author. And that's how this happened. But, of course, that's not the way it should be done. So what I think makes sense to do is move on and talk about what it takes to affect policy change and the importance of true partnerships. So if we could go on to the next slide then. And so we know, all of us know, so I'm not telling you anything new, the policy change is difficult because sort of while in theory, policy decisions are based on research, in reality,
Renee, I think we unfortunately lost you again. Are you still there? I'm sorry, Renee. If you're on a cell phone, perhaps you've encountered an area that is impacting that. I'm not sure if you're on a cell or a landline, but we're not able to hear you right now.
oh, gee.
Oh, now we can. Now we can hear you.
Well, you know, I am on a cell phone. That's the only phone I have access to. My bars are all the way up to the top, and I haven't moved at all, so I'm unsure. Okay, so I'm going to talk quickly. So unfortunately, maybe you didn't hear part of what I was saying. Did you hear the story of my connection with Amy?
Yes.
Okay.
We heard you all the way to, you were beginning to talk about, in theory, how policymakers make decisions.
Oh, okay. You can see it right here. So let's move on to the next slide. And basically, the theory based on research, the reality
I'm sorry, Renee, you're cutting out again, unfortunately.
Oh, gee. Okay, so why don't you just move through the slide? Can you hear me?
I can hear you now, yeah, but it's a little fuzzy.
Can you move through the slide? Can you move through the slide?
Yes, I can move through the slides.
Okay, so why don't you just do that?
Okay, so I'll move to the next slide.
Okay, so why don't you just move through the slide?
Okay, now I can hear you really, really clearly. So you must have found a really good spot for your cell reception.
No, you know what?
You know what?
No, I'm sitting in a chair and I haven't moved since we started. So I'm unsure. But so that we don't lose time and we have opportunity for discussion, if we could just move through the slides. And can you still hear me? Can you still hear me?
Yes, can still hear you very well, yes.
Okay, so why don't we just move through the slides, and that way we'll have time for questions, because I don't want it, for us to lose time with this, because I was just going to make general comments on each one, but let's just move through them. If you can look down each point, and then what seems the appropriate time, move to the next one.
Okay, so everybody, I'm going to move through the slides and try and give you all enough time to follow along, read the slide to get an understanding of it, and then I will move the slides to the next slide and save time at the end to make sure that you all have time to ask questions of Renee and Amy. So this slide is talking about, from the advocate's perspective, what are the barriers to promoting research for policy change, which I know is a topic that we think about a lot in the fellowship. I think a really good point on this slide is that policymakers do face, a million different competing priorities that draw their attention in different ways, and there are political risks inherent in any decision that they make, unfortunately. So this slide is talking about the failure to link evidence to policy and practice, and what happens when we're unable to link evidence. This is a good question. So when does evidence influence policy if it's difficult for that to happen in the first place? And Renee's points here are excellent. I think I've heard this point made quite a bit, the third point that, evidence is able to influence policy when there is some sort of relationship that exists between researchers and policymakers, whether they share a common network or they've met in person before and they have a level of trust, and they have a communication style that works for both of them and is clear and useful to both of them. I so appreciate all the reality checks that Renee is making for us in this presentation, that evidence is able to connect with policymakers under those three previously mentioned ideal circumstances, but that in practice this doesn't always happen because of the three points listed here. whether researchers have the time to connect with policymakers and interact in the political arena, whether their priorities align with policy advocates. That might not necessarily be the case, especially for researchers who may be like in tenure track positions. And yeah, as we know, making recommendations is really tricky. So Renee concludes this slide, therefore, developing researcher-advocate partnerships is essential to influencing policy. So yeah, how do we bridge the gap between these three groups that Renee was mentioning at the start of her presentation, and how do we, you know, ensure that we can find some common ground or shared priorities between these three groups?
So now, can you hear? Oh, if you could turn it back, if you can hear me.
I can hear you. Yes.
Okay. So if you could turn back to the last slide, because there's something I wanted to add about that. Because regardless of how collaboration is initiated, whether it's a reach out from a researcher to an advocate or advocate to a researcher, it's really important to establish a shared vision and goal for a joint project, and come up with specific research to policy goals that are clearly stated, understood, and agreed upon. And really say that this
Sorry, Renee, we heard you at the start of that, but then faded out a bit. So I may advance us to the next slide in the interest of time. And this slide is, it's talking about sort of researchers rebranding themselves as policy entrepreneurs who are able then to collaborate with advocates. I think that's something we talk about in the fellowship a lot, like the importance of, as a researcher, no matter where you see yourself going upon graduation, you know, part of maybe your responsibility as a researcher is to be engaged in the policy process in a different way than others are asking you to, or you've maybe thought of for yourself. Oh, and that is the end of the slideshow. So I'm very sorry, everybody, for these technical difficulties. I know that webinars can be a really frustrating format to share information, as evidenced by today's technical difficulties. The content here is excellent, and I, of course, will be sharing the slides with everyone afterwards. But now I think I'm going to turn it over to Leanne to step us into the question and answer portion of our presentation. So again, if you have questions, feel free to write those in the question box on your control panel screen. Looks like we have some already.
Yeah, thank you. Thank you, Sarah. Can you hear me okay?
Yes.
Okay. So one question we have is about some previous legislation. I'm just going to read it. It's my understanding that some previous legislation around 2008 required transition planning for transition-aged youth. Could you all talk a little bit about how well that legislation is enforced or tracked, and how transition-aged youth outcomes are reported in relationship to the plans made when they were emancipated?
I think I can at least start with that. So yes, the questioner is correct. As part of the Fostering Connections to Success Act, that was the act that extended federally funded foster care to age 21. There is a provision in that act that requires child welfare agencies to do transition planning with young people at least 90 days before they emancipate from care. However, to the best of my knowledge, no one is enforcing that, and no one is tracking that. So I think it's sort of on state's honor at this point. I don't think there's been much research at all on the content of those plans. I know that the legislation is includes a number of elements that those plans are supposed to contain, and I believe one of those elements has to do with health care or health insurance. But again, I'm not aware of any research that has been actually looking at those transition plans to see if they're actually being implemented. I can say that there are efforts. People may be familiar with the National Youth in Transition Database, and that is a mandatory data collection effort that states must do. They have to collect data from cohorts of young people at age 17, 19, and 21, looking at a number of outcomes. But I don't think there's been any effort, again, to link those data, those outcome data, to transition planning information. So I think the general answer to the question is we don't know much about it, but yes, there is legislation.
Great. Thank you, Amy. Another question was just about this, the term policy entrepreneurs, which, Renee, I'm going to make you see if you can talk or not, and if you can't, we won't keep trying again. But the question was, is that term policy entrepreneurs used widely, and do we know who coined it?
So, can you hear me?
Yes.
Oh, I was going to say, yeah. So, no, it's not a term that's used widely. It's only been used infrequently and recently, but we're trying to take it up as a term to really promote this focus on thinking through the potential impact of research for policy, and not just presenting the research, but being entrepreneurial in the way that you can ask the questions that focus on actionable steps that can be taken, and then understanding the policy landscape in ways that will enable you to share that, promote it in ways that are more likely to affect change.
I think I want to just add one comment to what Renee just said. I think increasingly, researchers are realizing that it's not very helpful for them to do their research and just produce kind of an academic-y, technical, peer-reviewed paper or technical report that gets submitted to some government agency that funded their work. Increasingly, researchers, at least the research that I've been involved with and my peers here at Chapin Hall, think about communications, and maybe it means taking a technical piece of academic research and turning it into a policy brief, or turning it into some other vehicle that is more accessible to non-research audiences, right? So if you take out a lot of the fancy, jargony, technical terms, but make it something that's much more accessible to people, so that it actually gets used, because, we produce a lot of very dense technical reports with a lot of numbers and terms, statistical significance, and we ran this test, and we ran a regression, and, a lot of that, it can turn people off, right, because they're not familiar with it. So taking your research, and I'm not suggesting that you dumb it down, but that you present it in a way that's more accessible to non-researchers. I just think that's becoming increasingly critical.
Thank you, Amy. Renee, this is another question that came in that's for you also. So we're going to continue crossing all of our fingers that we can hear you. And it's a question specifically about this brief, but it could probably apply to much of the work that you do. A lot of this brief, relates, or some of it relates to federal issues. And I think we all understand that the federal government is in sort of a different phase than usual right now. So the question is really, do you all work directly with states, or how does that actually work to get this information down to a state level? And from this brief or similar types of briefs that you've done?
Okay, so that's a great question, and can you hear me?
Yes.
Oh, good. That's a great question, and here's a prime example. We didn't do a great deal of, I shouldn't even say a great deal, work with the states around this, because we really didn't have the funding to do the project at all. It was just work that I felt was important and wanted to get done, and that was the other reason that the only staff I had were the summer CDC Public Health Scholars, one each summer, to get it done. But a prime example of the way in which we work with states on an issue is also an example of the importance of identifying or convincing funders to fund the kind of work that marries research with advocacy. So we were funded to update our family resource simulator and budget calculator for 3 states, Colorado, Ohio, and Florida. In each case, we created the ability to interactively figure out how much it takes for a family of 2, 3, 4, however many, to live in a specific county or city in each state. And then also the kinds of social safety net programs that are available. And then we would see these benefit clips about the difficulties that low-income families are having. In 2 of the cases, in Colorado and Ohio, we worked with an advocacy organization in the state, the Colorado Center on Law and Policy in Colorado, and Policy Matters Ohio, to actually promote the policies that we felt were lacking and what needed to happen to affect change. Because researchers do researchers, and we get funding and we move on, but if we work with advocates in those states, they can take that research and move forward with it. So those are the kinds of strategies we like to use.
Okay, thank you. Sarah, I don't know if you have any questions that you have. I've gotten one more in a chat box, so I'm going to go ahead and ask that, and then if you have any additional ones that anybody has sent you. Amy, this is maybe more for you, but I don't know. Either of you can answer it. It's back to the data on the 13 states versus the rest of the states. Is any research being done that you know of on what the health outcomes are for these youth in the 13 states that grant Medicaid access to all former foster youth versus the ones in the other 37? Is it 37? Yeah, 37.
37. I'm not aware of anything.
Okay.
No, and I am not either. Yeah.
Okay. That seems like it would be a lovely study, right?
It would be very. I'm just trying to think through how you would do such a study, right? Because you have to know you have to have a way of identifying young people who had aged out of foster care in a different state who had moved to another state, right? So it would be very hard to identify that population, right? It's not like if I wanted to do, research on youth who aged out in Illinois, I mean, that's hard enough. But now you're talking about doing research in one state on young people who aged out in other states. It's just it's hard to think about how you would actually approach doing that, given that we don't have any kind of national registry.
Right. And I guess in reality, the more important thing would be to show what Medicaid access in general for former foster youth, what that does for health outcomes, rather than just looking at the population of kids that have moved states and had an issue with that.
I can tell you, we did some research here in Illinois, I think 2 years ago. So it was after the provision had taken effect. And we did interviews, we did interviews with young people who had very recently aged out of care. They were all 21 and a half years old or so, something like that. And these were all young people who were pregnant or parenting at the time that they had aged out. And one of the things we asked them was about their Medicaid coverage. Do you have health insurance? What type of health insurance do you have? And a number of the young people we talked to didn't. So these young people were falling through the cracks. And so it goes back to that point, we made earlier, that just because we have this policies in place that says states have to provide Medicaid, it doesn't mean it's happening in practice. Young people are falling through the cracks for various reasons.
Okay, thanks. Sarah, I know you said you had a question or two that you've gotten.
Yeah, I was wondering I have a few questions. Renee, I was wondering if you could share, the best practices that NCCP has used to, to get documents into the hands of policymakers. I guess I'm most curious about, like, how does NCCP, or how would you advise fellows to determine who is the best recipient of their research? I imagine that in some cases it's really, really obvious, but I also imagine that there are times when there is an audience that would really benefit from the research that, a fellow might be conducting that doesn't seem as obvious. Just wondering if you could speak to that, if we can hear you. Hopefully we can.
Okay, so can you hear me?
Yes, perfectly.
Okay, good. So you're right. In many cases, it's quite obvious who to attempt to reach out to. They very simply through looking at policymakers, areas of focus, the kinds of bills that's proposed, and all of that is readily available. But the problem, though, so one is policymakers, but again, because often you need the work of advocates in order to affect the kind of change or push the change that's needed, that we look to organizations that are advocacy organizations. Some of them are partners. In some cases, because we're in New York, we may not know the advocates in other states. We look to networks of advocates, our colleagues, to make recommendations to us. But truthfully, what we found most effective in reaching a large number of stakeholders is through the media. And we end up, and we've just been doing this recently, we have a communications consultant who, anytime we're about to release a new policy brief, now we just started it, will work with us to do a media briefing, identify media journalists across the U.S. who have reported on a specific issue, have a media briefing, send them their report, and then have an hour call with them in order for them to ask us questions, for us to give a summary in case they really don't have the time to review it carefully. That started to work out well for us, and what we found is that if we can call out in those briefings the kinds of problems and barriers that exist in affecting change, the media often, because they want conflict, they often pick up on that. And we've had a couple of op-eds, we've had a couple of editorials focused on the reports and the kinds of policy change that's needed. So I think that identifying advocates that have a focus on the areas in which we're working, and to identify media to sort of get it out there and put on the pressure, are things that have been effective.
That's great, Renee. Thank you so much. I actually know that several of the fellows who are on this webinar right now recently published an op-ed in the Huffington Post, and so yeah, I think fellows are thinking about media as a tool for research dissemination. So it's cool to see that other folks are thinking about that too. I just have a final question for either or both Amy or Renee. You know, part of Renee, your presentation talked about that. You know, sometimes researchers, policymakers, and advocates don't share the same priorities, and so collaboration can be difficult. And I was wondering, you know, if a researcher might ever pick a research question or design a research project in collaboration with a policymaker or an advocate, and if so, you know, what would be the best place to involve those people, at which stage in the research process? And I don't know, Amy, if you've ever seen any collaborations like that take place between, you know, a doctoral student or a seasoned researcher.
I don't think I've seen, well, I mean, for example, I have worked with a number of social service agencies, child welfare agencies, homeless services agencies, where they've had questions that they wanted answered, and that I've been able to either use data that they already have in-house that they don't know how to analyze, or collected additional information to answer those questions. So, I mean, I don't know if that's, I guess that's a collaboration of sorts. I've never collaborated with anyone, like an advocate or a policymaker, where they've been involved in the actual design of a research project. But they've often been the impetus for a project.
Yeah. Well, wonderful. I think since there are no more questions, I'm going to wrap up our webinar. Thank you so much to Amy and to Renee for being with us. I do apologize to everyone for our webinar sort of snafus. I know you did not get on this webinar to hear little old Sarah Wagner give Renee's wonderful presentation. I am so not qualified to do that compared to Renee. So I do apologize for that. And thank you so much for your flexibility and your patience with us. Again, I will post the recording and the slides. We'll share that with all of you by the end of this week. And look forward to seeing you all in September, and to our grad fellows, seeing you at conferences this summer or at the mid-year meeting. So I'm going to end it there. Thank you so much, everybody. Take care.
Thanks. Bye-bye.